Hey, welcome to week 1. In this presentation, we will be discussing concepts and principles of primary care that are the foundation to the practice of every family nurse practitioner. My name is Dr. Tracy Murray, and I'm a full-time assistant professor with Chamberlain University and the faculty course lead for NR 511. Primary care is different than tertiary care. The types of problems that are solved in primary care are different than those seen in acute or critical care settings, which you may be used to as a bedside nurse. Upper respiratory infections, abdominal complaints, skin rashes, and vague somatic complaints are problems that are not often encountered in the hospital setting. Even chronic conditions present differently in primary care. Hypertension, CHF, arthritis, and diabetes present with day-to-day management problems that are different from the crises that acute care nurses must respond to in a tertiary care setting. As you'll soon find, primary care is a new world with a different set of problems to be solved, different kinds of constraints and choices, and a different culture of care. Diagnosing and treating up to 30 different patients or families in a day is both challenging and mentally exhausting. Although an office visit allows for focused one-on-one care with an individual patient, the NP must still recognize that healthcare is a business. In order to meet office overhead costs, including provider and staff salaries, the business must be profitable or at least have equal income to operational cost margins. Because of this, a nurse practitioner needs to have a solid understanding of how to obtain and process information in an organized approach. Learning to practice primary care in an artful way requires a certain kind of thinking. The mental task of eliciting and sorting through large amounts of data, clustering data elements into meaningful patterns, connecting patterns to reasonable diagnostic statements, considering risk factors, and selecting appropriate interventions require a high level of diagnostic reasoning. Diagnostic reasoning can be seen as a kind of critical thinking. Critical thinking involves the process of questioning one's thinking to determine if all possible avenues have been explored and if the conclusions that are being drawn are based on evidence. Diagnostic reasoning then includes a systematic way of thinking that evaluates each new piece of data as it either supports some diagnostic hypothesis or reduces the likelihood of others. Developing expertise as a nurse practitioner takes time. Students who are experts in the hospital or specialty care become novices in the advanced practice role. Clinical judgment and diagnostic reasoning is based on experience. As a student, you will hopefully gain skills to function at the advanced beginner level through didactic work and the added clinical practicum experience. It took years for you to become an expert nurse, so you can expect that it'll take years to become an expert NP. On your journey towards graduation from the FNP program, you will be given the necessary tools to help you be successful on the board certification exam and become a competent advanced beginner. The type of data that you collect depends on the type of visit. Most visits are episodic or problem-focused, where one or two specific issues need to be addressed. One thing I want to point out is that the information in the H&P should only be relevant to the complaint or problems that you are addressing. So, a patient with a skin complaint does not need a full H&P. Rather, a focused history and exam as it relates to the skin complaint or associated symptoms should be recorded. First, I want to go over two important distinct concepts that seem to be an area of confusion for many students: subjective and objective findings. We will discuss these in more detail when we introduce the SOAP Note lecture. But to start, subjective information is what the patient reports, complains of, or tells you in response to your questions. Examples of subjective information include the following. Under constitutional, fever, chills, lethargy, weight loss or gain. Under HEENT, headache, blurred vision, otalgia, sore throat. Under neck, swollen lymph nodes. Under lungs, shortness of breath, complaints of cough or wheezing. These are all examples of subjective information. Subjective information is the S part of the SOAP note, which includes the chief complaint, the HPI, and the review of systems, as these are all things that the patient reports to you in an interview. Objective information is what you can see, hear, or feel as part of your clinical exam. It also includes laboratory data and test results. Examples of objective information include the following. Under constitutional, you might list well-developed, well-groomed, thin, cachectic, obese, and so on. Under HENT, normocephalic, PERRL. Under neck, the anterior cervical lymph nodes are swollen and tender. The lungs, clear, wheezing in the right lower lobe, bronchospastic cough. And under results, you might list the CBC, a strep test, the UA, the chest x-ray, and so on. The objective information is the O part of the SOAP. Eliciting a detailed patient history through open-ended questioning and active listening offers critical clues to determining a diagnosis. Obtaining a meaningful history involves collecting subjective information and organizing it into meaningful chunks of knowledge. Data acquisition in history taking is most effective if it is hypothesis-driven. In other words, when the information selected and gathered is related to the list of possible diagnoses. Hypothesis-driven data means that data would confirm or disprove a specific hypothesis is specifically sought and recorded. However, obtaining data that fit one possible problem is not enough. Competing hypotheses must be ruled out by seeking additional data, and the provider needs to consider that the priority list of hypotheses may change based on new information. For example, symptoms of runny nose may be due to a viral infection. If in the history taking the provider specifically asks if these symptoms have occurred before, and the patient replies, yes, this also happened 2 weeks ago, the likelihood of a viral infection decreases, and the likelihood of an allergy increases. In other words, your hypothesis for the etiology of rhinitis has now changed. The chief complaint is a one to few word statement identified by the patient as the reason for their visit to you today. Try to identify the chief complaint in this scenario. Johnny, a 5-year-old, is brought to your office by his mother. The mother reports that the school nurse called because Johnny said he had a tummy ache. Several other students in the school also have complained of some GI symptoms. He did not throw up, but he says he feels like he could. In this case, an acceptable chief complaint would be nausea or tummy ache. It's short and to the point. You'll expand on this information about the chief complaint in the history of present illness. The HPI is a detailed breakdown of the chief complaint, written out as the old CARTS acronym. Each letter in the acronym represents important information about the chief complaint, which will help you develop a differential diagnosis. The HPI is focused on the chief complaint only, so each letter of the acronym should address that one issue. Any additional information that you feel is pertinent to report in the case, but is not directly related to the chief complaint, should be reported in the review of systems. In the HPI, the O stands for onset, L location, D duration, C characteristics, A aggravating factors, R relieving factors, T treatments, and S severity. There are 2 things I want to point out here. Do not get confused on duration. Duration is not referring to the onset of the symptoms. Rather, it is an assessment of whether the symptom is constant or if it comes and goes. Also, don't forget to ask about severity. Severity refers to the level of pain, which might be reported on a pain scale, or how the symptom has impacted the patient's ability to go to school, to go to work, or to perform their daily routine. This should be included in every HPI. Be sure to watch the video lecture on the review of systems, which again is an assessment of subjective information. Because you have successfully completed NR 509, it's expected that you're competent in performing a head-to-toe physical exam. Although some of your patients may present for a complete physical where you need to address all of the body systems, you must now learn to focus your assessment skills to be appropriate for the patient's complaint and history as part of the problem-focused visit. This will become clearer as you go through the lecture on billing and coding. Differential diagnosis, or the differential, is a list, which is single, of plausible diagnoses, or plural, that fit the historical and clinical presentation of your patient in order of priority. This is different than the problem list, which is a list that includes all of the active medical problems for the patient. You'll be seeing these in your clinical rotations, but for the purposes of your first clinical course, we will not be putting together problem lists. The focus in this course is on how to formulate a differential diagnosis. There is a separate video lecture on the differential diagnosis for you to view this week, which presents the concept of formulating a differential diagnosis in a meaningful way. Diagnostic tests can be used to confirm or to rule out hypotheses. They may also be used to screen for conditions or monitor the progress in managing a chronic condition. Diagnostic tests vary in usefulness based on sensitivity, specificity, and predictive value. When we describe the specificity of a test, we're referring to the ability of the test to correctly detect a specific condition. If the patient has the condition but testing is negative, we describe this as false negative. If the patient does not have the condition but the test result is positive, this is considered to be a false positive test. When a test is very sensitive, we mean it has very few false negatives. The higher the sensitivity, the lesser the likelihood of a false negative. A sensitivity of 99% means that it is very unlikely for a false negative result. In a perfect world, a test would have 100% specificity and sensitivity, but we know that's not the case. Therefore, it's important to consider the specificity and sensitivity of a test when considering its usefulness in ruling your hypothesis in or out. Predictive value is the likelihood that the patient actually has the condition and is, in part, dependent upon the prevalence of the condition in the population. If a condition is highly likely, a positive test result is more likely to be accurate. If a condition is very unlikely, a positive test needs to be questioned and perhaps additional testing would need to be done. When deciding whether or not to order a test, 5 things should be considered: cost, convenience, sensitivity, specificity, and the risk of missing a condition, or the predictive value. In today's healthcare system, patients are encouraged to be proactive and informed members of the healthcare team. One method that is advocated by popular groups such as AARP, the NIH, and the CDC is for patients to create a list of questions or issues for their provider visits. Lists can be challenging for providers because many patients have the unrealistic expectation that their provider will address every item on the list. You'll see this frequently in your practicum rotations. The reality is that the medical office is still a business, and time constraints often prevent providers from addressing every issue in one visit. Prioritizing the patient's needs while maintaining the allotted time requires a patient-centered communication approach. Although you may not be able to cover the list in its entirety, this approach acknowledges to the patient that you hear their concerns and together have developed a plan to address them. This tactic not only improves patient satisfaction, but helps keep the provider on schedule. In the next few slides, we'll be discussing a useful approach to prioritizing a patient's list. Keep in mind that these are suggestions and not rules. At the beginning of each practicum rotation, I encourage you to discuss with your preceptor how he or she deals with this issue. Some offices may have a policy in place, or the provider may have a personal preference in handling prioritization of the patient's lists. These suggestions may not be the best approach for the practice setting that you're currently in, but may be useful in another office or in your own practice. Acknowledge the patient's list of questions and concerns. It's important to acknowledge that the patient took the time to prepare for the visit in compiling a list. This can be done simply by stating, "I see you have a list of concerns or questions. Let's look at it together." Mutually negotiate what to cover during the visit. If the patient's list is too long or does not match your own priorities for the visit, you'll need to negotiate which items you'll address at the current visit. The key to negotiating process is to use positive language. So instead of saying, "We don't have enough time to discuss all of these," a better approach would be to say, "I'd like to cover as much as we can from your list, but I also want to take a few minutes to talk about your diabetes or hypertension or COPD, etc." Be honest. Being honest about the time allotted for the visit while planning jointly on how to use that time is important. To take this approach, you might say, "Since the visit is only scheduled for 15 minutes, let's decide on the 3 most important issues for today." Most patients are willing to accept this, but occasionally there will be a more demanding patient. In cases such as this, being honest and telling the patient that in covering all of the issues, you cannot be as thorough. And make a plan for follow-up. Mutually set an agenda and time frame for the next visit. Recap what you were not able to address at this visit and what you intend to go over the next time. If a patient is overdue for an annual physical, you might make the recommendation that one is scheduled, since more time is typically allotted for these visits. Be sure to document this plan in your note as a reminder to you for the next patient visit. All healthcare providers are called to provide evidence-based care, which involves providing care and making treatment and screening choices based on current research findings. Generally, evidence-based practice refers to using research findings from multiple studies that are convincing enough that a consensus is formed, recommending the findings be used for clinical decision-making or practice guidelines. Evidence-based practice also involves inclusion of patient and provider preferences, patient values, and cultural considerations in the clinical decision-making process. Guidelines should be followed in the majority of cases unless there's a clear rationale for deviating from them to serve the particular needs of a patient. There are some examples of clinical practice guidelines or evidence-based guidelines developed by organizations or agencies that I've listed here. Some examples are for allergen immunotherapy, the American Academy of Asthma and Allergy group is one example. The Infectious Disease Society of America is also another group that puts out clinical practice guidelines. And now that you understand each individual component of the history and physical, it's time to document and record your information in a SOAP note. SOAP notes are used to provide accurate information about the patient's status and the visit. They include the subjective and objective findings from the history and physical, as well as your assessment or diagnosis and plan. Please view the video lecture on SOAP notes.